Thank you. Thank you for the invitation. Just a slight correction. I know nothing about cardiac imaging. I'll be talking about imaging in cancer therapy. So also a bit of introduction. I'm very much an end user of the technology, very different from all of the speakers so far. So what I'm trying to do is to show you what a lot of the talks are focused on diagnostic. I think Dosimetry yesterday talked about cancer imaging from a diagnostic perspective. And I just want to highlight the role of imaging in the treatment part of cancer. So just a bit of introduction to the hospital. So UCL Hospital, just a few miles from here, is partnered with UCL, the university, and forms the largest academic health centre in Europe. And it has its real focus from a clinical research point of view is in neuroscience, and there's a lot of neuro imaging and neuro-oncology imaging, and on cancer. And so from a clinical point, they have a large sarcoma service, extremely large pediatric service. And so cancer research is our focus from a health point, with neuroscience becoming a very close second. And obviously there's a large amount of imaging needs in each of these. So my talk will focus only on radiotherapy, which is approximately 60% of cancer patients will undergo radiotherapy at some stage in their treatment. And also just to highlight, we focus a lot on proton therapy. So we're having a centre, well, in a couple of years' time. It's currently a massive hole in the ground, but we'll eventually grow into this. So imaging for us is X-ray and charged particle. So looking at where imaging falls into the cancer therapy or the radiotherapy patient pathway, we have areas before the treatment where post-diagnosis you need to plan the treatment. So get a second very high quality image, and then at the time of treatment, when the patient's in the treatment room on the couch, also applies in surgery, where you need to position the patient accurately to steer the beam, where we use a lot of, a lower quality X-ray CT, but also optical surface mapping, just to make sure the patient is correctly positioned. The ultrasound also features. And also you need to check if the patient has changed from day to day. So this, I'll come back to this because movement is a key issue. There's a lot of movement, anything from the head to the pelvis moves during the course of therapy. Unlike diagnostic imaging, which is instant, therapy can take several minutes. And the patient can change a lot and move a lot during this time. And then after the treatment, you need to check that you've done it correctly, and you need to sort of follow up and see how the patient has changed post-treatment. So looking at before radiotherapy treatment, so post-diagnosis, when you already know the prognosis, we want to precisely delineate the soft tissue volume. And so separating the tumour from the surrounding healthy tissue. And so to do this, we need to know exactly what the tissue is that we're looking at. And this is, I guess, down to about 1/4 millimetre is needed. If you could go lower, you would. And then bringing all this information together. So typically by the point that the patient has radiotherapy, they've been imaged loads of times. There's lots of information and historical genetic information about the patient. It's bringing it all together, of which the imaging forms a very key part of that. And quantitative imaging is critical, and also standardization. So if a patient has a quantitative image in one centre and they get referred to another one, it has to be exactly the same. So looking at a few areas for us, this is very much a software. So what we do with the picture really matters. So the patient will have a high quality X-ray CT at the planning stage, and often, or certainly for the brain patients and some other parts of the anatomy, they would also have an MRI. And different quality of information, different types of information, but we need to merge it into the same picture to get information that you can actually plan the patient. So software and the endpoint and matching deformable images is key. Very much a future for us in radiotherapy is dual energy CT. And at the planning stage. And the benefit of this is that you can get quantitative information. So you can actually identify the tissue property and the tissue type. So what we're interested in for planning the patient is electron density. And dual energy CT can potentially get much better accuracy on this, which leads to a better quality treatment plan and better outcome for the patient. And some work we've been looking at, I mean, the images aren't particularly good, but really just to show that if you're looking at electron density or atomic number or into protons for the stopping power, then with dual energy CT, we can get far better accuracy, so plus or minus 1 or 2%. We can't achieve this with a single energy X-ray CT. And very much a key thing, a key need for cancer therapy is four-dimensional imaging. A lot moves. This is just to highlight a lung tumour as you rotate around the patient. It's highlighted because they're very difficult to see, very low contrast. But the point is we need four-dimensional pictures. 2D, 3D, is okay in some cases, but if you're trying to treat the patient over several minutes or do a surgical procedure, you have to know how the patient moves. And typically lung cancer patients, their breathing isn't as good as a typical person, and so it can be quite erratic. And so what we're trying to do is target the tumour at the time of treatment. So that was before the patient has their treatment, and now during. So the patient is now on the couch, being positioned precisely. We need to position them to better than 1 millimetre, ideally. And so looking at why. So why do we need to image during the treatment? This is a single patient. It was a child that was undergoing radiotherapy. And this is so these highlight bowel gas within the patient. Pediatric patients are quite difficult to manage, and they're eating and drinking and so on. But from day to day, so if you're trying to fire in an X-ray beam through this patient, then the position of the dose varies very much depending on how much gas there is in the path compared to normal, compared to soft tissue. And so this changes a huge amount, and that would dramatically change where you're positioning the dose within your target. And similarly, we looked at another patient group, again pediatric patients, and for a single patient, this is how the kidney moved. So radiotherapy is done typically 20, 30 times, 5 days per week over a few weeks. And this is how the kidney has changed each time. The kidney is very radiosensitive, and so the movement really affects where you can fire in the beams to the patient. So we have to get accurate day-to-day information. Another example. So this is through the lower part of the head of a patient, just a slice, and we have an outer darker grey picture, which is how the patient was towards the start of their treatment, their radiotherapy treatments, and this is a few weeks into the treatment. And because they're having cancer treatment to the throat area, they have difficulty eating, and so they can lose weight, and which again will change the delivery of dose to the tumour site. And so this, again, we have to know this precisely. So coming back to the motion issue. So the tumour, so if we imagine a lung tumour, anything near the diaphragm or within really a couple of foot of the diaphragm will move up and down or in various directions. It tends to be a fairly elliptical path. And ideally what we'd want to do with radiotherapy is to track the tumour up and down and only hit the tumour. If you're hitting the healthy tissue surrounding it, then you can cause damage to the lung of the patient. You can actually induce cancer because of the treatment. And so what's done at the moment, so this outline shows the dose that would be delivered to a lung cancer patient. And it's covering a lot of tissue here. And also, it's not just the lung tissue you're hitting, it's passing through, it could pass through the heart, the spine, and other organs surrounding it. And so, ideally what we'd be doing is just gating. And so whenever the tumour is at a particular point, you fire the beam then, your treatment beam then. And obviously you're sparing all of this tissue here, which reduces complications and side effects and later effects. Potentially years on with the patient. But obviously we have to know where the tumour is at the time when we're delivering the beam. And so to do this, we need some kind of external signal. So this could be imaging the patient, either with X-ray to see where the tumour is moving, or we could do it surface with an optical scan. But it does take longer if we do this gating method. And so ideally, we would know exactly where the patient is, so predict the tumour motion, and be able to track it in real time. That requires a live 4D image. Cone beam CT is very routinely used. This is a slightly lower quality 3D image. It gives lower dose, which is important. There's ongoing arguments about how much dose you can give to a cancer patient. They come every day, 20, 30 times. So the dose does add up over time, which is a concern. So lowering the dose is critical, and speed is important. So being able to image the patient on the couch in less than a minute is important. Imaging technology, I'll just put this is one of Renato's sensors, a large area digital imaging sensor that we've been looking at for dosimetric and imaging purposes. And so it's important for us that any sensor that we use has quantitative information, and usually, so we want spatial resolution. And obviously these sensors match very well with films, but it needs to have dosimetric information. So this is effectively dose on this scale, and the gold standard is an ionization chamber, and we need a quantitative image from the sensor that is equivalent to what we can achieve with an ionization chamber. And so obviously a digital sensor that can give us film-like spatial quality and the quantitative information that we can get from a dosimeter is very attractive. And ultimately where we want to go in radiotherapy is, I showed earlier how the patient changes from day to day. We want to do what's known as adaptive radiotherapy, where every day of the treatment, as the patient changes, as their tumour shrinks or they lose weight or there's something different in the body, we want to change the treatment such that it's exactly right each day. So we would take an image of the patient at the time of the treatment, compare that image to the original one where the plan was made, and then if they're the same, just proceed. If they're different, we want to, on the fly, modify our treatment plan. And we're talking quick. It's got to be a couple of minutes that we need to get all of this information processed and modified at our plan. And this is very much a kind of a need for future radiotherapy. So we need, everything's got to be done very quickly and validated such that we can be ready for clinical use. The field is very much heading in, or there's a need heading in this direction. What we do at the moment is very much a short-term fix, in that we have a high-quality X-ray CT for the planning stage, and then we have these daily cone beam CT, so the lower quality, low dose versions. These aren't good enough. The quality isn't good enough in terms of the quantitative information. The image, the spatial resolution is okay, but the quantitative information isn't good enough that we can modify a treatment plan. So we have to somehow take what we're seeing of the daily anatomy and modify that to get the quantitative information to our original high quality image. This is a quick fix. Ideally, on the day of treatment, we would get good quantitative information, which is dose information. Proton radiography or proton therapy. So ideally, any patient that is having proton therapy, which in the UK would be about 1% of all radiotherapy patients would have protons. And these, on the NHS service, these will be many paediatric patients, so about 400 per year, or people with tumours at the base of their skull. And so we want to take an image of the patient with the proton beam, which reduces errors. And here's a picture that we took. It was at the Harvard cyclotron at Mass General Hospital of just a plastic mock-up of a brain. The image quality is not good, but this was very much the first one that has been taken. And so being able to look at charged particle imaging with large area imaging panels is going to be important. I think Phil Evans spoke yesterday on the Pravda project, and they also are sort of looking for sort of multi-layers of charged particle sensors. And treatment verification. So this is at the time of treatment or sometimes afterwards. You need to check that this has been done correctly. Cancer can recur. Many tumours can recur after it's been successfully treated. And it's becoming a legal requirement that we need to check, has the patient been treated correctly and they were just unfortunate that the cancer recurred, or was there some error in the way the treatment was delivered? And so at the moment, we just can't do it. There's no technology available to do this. But if the law is coming in that when it becomes available, we have to do it. So what we need is a quantitative map of where the dose went in the patient. And there's a technique known as transit dosimetry, which is seen as a way of doing this, in which you would have, your patient would be here, and the radiotherapy beam would pass through onto a large area imaging panel, and then you would be able to quantitatively guess, you know how much dose you're giving to the patient, you know how much dose you're getting out of the patient, so guess what was left in the middle. And other ways of doing this, surface diodes that you can put on the surface. This is seen as not ideal compared to this technique. If you can get a large area image, this is better. Or placing a diode internally. If you can get it small enough, you could actually surgically implant it in the patient. We're talking, sort of 2-3 millimeters. If it's larger, you can put it within one of the body cavities, and there is a need for this. Just quickly, it's less on the X-ray side, but something that does happen during proton therapy is you make the patient briefly radioactive, just for a few minutes, and so you get, or instantly, you get gamma rays emitted that where you can see where the maximum dose is within the patient, and you also generate positron emitters within the patient, which you can put them on a PET scanner. So that there is information coming off. For the X-ray area, or X-ray sensor area, this could be an area of interest. And other things you get, PIXI, or proton-induced X-ray emission. When a proton hits a material, it becomes radioactive, or you get some kind of nuclear decay. And you can get X-rays being emitted from it. And if you implant something in the patient, you can have a sensor outside of the patient that can tell when this has been hit. The application that we looked at is this is a patient having a treatment for a tumour on the back of the eye. And what was done is a small metal marker was positioned on the back of the eye, and if the X-ray beam, or if the proton beam hit it, we got X-ray emission, which we had a sensor outside of the patient, and that told us if the proton beam had gone too far. If it goes too far, it hits the brain, the optic nerve, which causes a lot of problems for the patient afterwards. And this is just, we did it at the beamline in Sicily, just showing a mock-up of a plastic version before we actually tried it on the patient. And so that covers all the imaging needs in patient radiotherapy, but there's also imaging sensor needs for preclinical studies. Preclinical is anything in which you haven't yet proven the technique that you can try it on a patient. Much of this is drug-based. Obviously, there's not a lot of applications for imaging sensors for drug delivery. But one area where there is, so let's go on to the next slide, is in nanoparticles. So cancer nanotechnology is starting to grow more and more as a subject. And nanoparticles are you can attach drugs to them to deliver the drug to the right point. So you take a small particle. Gold is one that's got clinical approval so far because it's non-toxic, inert. And you can coat the gold with a chemical that makes it seek certain parts of the patient, for example, certain cancer cells. It will go straight towards them and then be absorbed by them. And you can attach, so chemically, you can attach drugs to them or something. And so the nanoparticle is used as the vehicle for getting the drug in. And so what you can get with the nanoparticle, for example, gold, you can see it. This is electron microscopy. just to show the scale of the things. But if you were to put enough gold within the tumour cell, you can see it quite clearly on X-ray. This has been done for enhancing mammographic tumours. And as the tumour cells fill up with this gold, it just becomes much more visible. The resolution needs to, not at this scale, but down to a few microns. We'd need that kind of resolution for preclinical testing, just to check where the nanoparticles are going, and therefore where the drugs are going within the cells. And we tried it just with very simple sensor technology to look at the concentration of nanoparticles, and you can get the resolution isn't so great here, but if we could go down to 10, 20, 30 microns and be able to see nanoparticle distributions, then we could start to see at cellular level where the drugs are being delivered. Okay, thank you.